Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Please feel free to ask questions in the chat box as we go along, and they'll be addressed. I am honored to introduce our mentor for today, Dr. Zia. Dr. Zia completed her residency at Henry Ford Hospital in Detroit, and she is currently completing a GI/liver pathology fellowship and serving as a pathologist at the University of Nebraska Medical Center. As she progresses in her career, her primary goal is to become a distinguished GI/liver pathologist, making a substantial impact on patient outcomes, advancing medical knowledge, and collaborating with fellow experts in the field. And now it is my honor to request Dr. Zia to begin today's session. Thank you.
Thank you so much. Thank you, Chen, for such a nice introduction. And I'm very honored and pleased to be a part of the program and to be here. So let's see how we go about it today. That might be a roller coaster ride, but let's go about it. So I'm going to talk today about the cystic lesions of pancreas, and my references, they include some of the articles that I have indicated in the presentation, the Sternberg Surgical Pathology, the new WHO edition, and some online resources like Expert. Yes, so the goal of my presentation would be I'll walk you through some clinical case presentations, and then we'll review the differential diagnosis, including the clinical scenario, imaging, FNA, cytology, microscopic findings, and then we'll walk through the WHO classification and how we can integrate a multidisciplinary approach to do the correct diagnosis regarding the pancreatic cystic lesions. So the first case is there was a 55-year-old female, and she presented with abdominal pain that was associated with jaundice. She has a history of chronic recurrent pancreatitis for about 25 years. So on CT scan, there was a diffuse atrophy of the pancreas with multiple calcifications. There is cystic change that was around the pancreatic head and uncinate process. Later on also, as she was being followed up after a year, there were still changes that were associated with chronic pancreatitis. Even after 1 year later to that, there was some cystic structure that was seen in the pancreatic head that measured about 5.8 centimeters in the largest dimension. Again, following up, the impression from her imaging was that there was a hypoechoic mass in the region of pancreatic head, and then the pancreatic cystic lesion perhaps was just a sequel of her prior pancreatitis, or probably that was associated with duodenal diverticulum. So these are the imaging finding and the mass that I was talking about. And then regarding her obstructive jaundice, so her labs were coinciding with that, as she had a high AST and ALT level. ALT was reaching in thousands. Her total bilirubin was 8.5. Then CA19-9 is one of the markers that was done. It was 494. And that lesion was seen to be communicating with the bile duct as well. So there was dilated common bile duct, and there was intrahepatic ductal dilation as well. So then we do FNA from cytology. And as you can see over here, this part of the FNA is how probably a normal common bile duct brushing looks like. They are maintaining their cellularity, like they're respecting each other, and they're in a form of a honeycomb pattern. Whereas if you compare this to this, there is a drastic difference, and the cells are losing their kind of arrangement, and they're more pleomorphic, and they're more hyperchromatic, and they're atypical clusters of epithelium. So then that was labeled as suspicious for malignancy. And then later on, when they did biopsy of the lesion, so you can appreciate this one over here. This is the normal duodenal epithelium. And then in here, there was this haphazard kind of very malignant looking atypical glands, like you can see, and they're in the background of mucinous epithelium. And then we do immunohistochemical stains to see what those glands were staining with. So they were strongly positive with CDX2, and that is a nuclear stain. And then they were positive focally with CK20, and then negative for CK7. So positivity with CK20 and CDX2 more so points towards intestinal origin. So this was termed as as suspicious, or this was a pancreatic adenocarcinoma, and this was more likely an origin from an IPMN kind of cystic lesion of pancreas. So if the intestinal type, there are different types of IPMN, we will talk about it. So that one, this is not a usual pattern for a pancreatic adenocarcinoma to stain for, but intestinal type IPMN stain with CK20 and CDX2, and they can give rise to more so colloidal kind of adenocarcinoma in the pancreas, as seen in this example. So why I'm talking about this is just to give you an overview that how those cystic lesions of pancreas, they can progress to pancreatic adenocarcinomas, and why it's important to diagnose them. Because as we know from American Cancer Society, the pancreatic adenocarcinoma is the 10th most common diagnosed cancer in United States. It's a third leading cause of cancer deaths in the States. And in 2020, even the newly diagnosed pancreatic cancer cases, they reached up to 60,000 new cases in that year. And amongst all of those, about 15% of them, they arise from cystic lesions of pancreas. And that's why it's very important to timely diagnose them and have a multidisciplinary approach to how to approach those lesions to kind of resect them, and the patients can undergo Whipple procedure and have a right treatment modality and plan. So this image is just showing you how the pancreatic duct goes through different genetic and epigenetic alterations, including KRAS, CDKN2A, then TP53 and SMAD4 loss, and can progress towards the invasive cancer. So that this one, as I have mentioned in the references, I just took to show you how the pancreatic cystic lesions are categorized. So they can be mucinous or non-mucinous, that is included under the umbrella of neoplastic cystic lesions of pancreas. And then there can be non-neoplastic pancreatic cysts. They include very little percentage of it, and more than 50% of the cystic lesions, they include this category, neoplastic cystic lesions of the pancreas. So non-mucinous include serous cyst neoplasm, solid pseudopapillary or cystic neuroendocrine neoplasms, whereas mucinous include mucinous cystic neoplasm and IPMN. So coming to another scenario, and then we can walk through different cystic lesions of pancreas. So this one talks about, there was a 72-year-old female. She was Caucasian, and she had an extensive history of peripheral vascular disease. So her history included negative for diabetes, heart disease. She was being closely followed up by the surgeons because of her peripheral vascular disease history. And during her follow-up on CT angiogram, there was a multilobulated cystic mass that was centered in the pancreatic head and was communicating with the main pancreatic duct. In the largest dimension, it measured up to 6.9 centimeters. And on EUS, that multisubtatic cystic lesion in the pancreatic head, it showed that there was a suspicious mural nodule associated with it as well. So FNA was done, and there wasn't any malignant cells that were seen. That was a very paucicellular specimen. However, CA19-9 and was 9.8, CEA was 2.2. This is the lesion that I'm talking about. It was communicating with the main pancreatic duct. So further on, the patient underwent Whipple procedure because one, of the size of this that was increasing in size, and secondly, the mural nodule, when it's mentioned in the imaging, that's one of the suspicious findings. And then third thing is when it's communicating with the main pancreatic duct. So those are all the suspicious things that were highlighted during her workup. So then the patient, when the grossly that specimen was examined, there was that cyst-like structure that had diffuse papillary excrescences, and there was viscous mucus in there. The common bile duct was dilated. The diameter was about 1.9 centimeters. This is the histology of that. So you can see there were multiple ducts within the pancreatic parenchyma that were dilated, and there is this fibrotic stroma in the background around all of those dilated ducts. And those ducts which are dilated, they have these papillary kind of excrescences that are growing in there. And I'm going to show you a higher power picture. And over here, you can appreciate there are two kinds of lesions. This one is different from this part of the lesion. So this looks more, in common terms, we can say more bluish and more hyperchromatic as compared to this part of the lesion. So on higher power, the upper part or some of the parts of those papillary excrescences, they showed, if you can appreciate these, this is a low grade lesion. So why I'm calling it low grade? Because all of these nuclei, they are very basally oriented and there is still apical mucin on the top. So this was a low grade part of the lesion. And then these ones are pretty different from the one that I showed you before. And these are losing their polarity. All of the cells that were very basally located in the previous image, the cells or the nuclei, they are haphazardly oriented. They're losing their polarity, and architecturally also they're forming these micropapillae. So these are more cytologically and architecturally atypical. So that's why it was diagnosed as IPMN, like meaning by intraductal papillary mucinous neoplasm, with both low grade and high grade dysplasia. Their maximum dimension was going to 4.5 centimeters. And then when you are identifying something as IPMN, you have to tell whether there was an associated invasive cancer with those lesions or not. So there wasn't any invasive cancer that was identified in this case. So this is, I'm just putting up to show you how it is worked up. So this is from the ACG guidelines to working up cystic lesions in the pancreas. And then like we mentioned before, they have to see these positive features, like if you're seeing dilated main pancreatic duct, the size of the cyst is more than 3 centimeters, or if there is a solid component associated with it, then the patient will undergo EUS or FNA. And if there is a concerning cytology or more than 2 features, then they'll undergo surgery. Otherwise, they're followed up at an interval of 1 year MRI, and then after that biannually for 5 years. Comparing that to AGA guidelines, these are different clinical guidelines to work up patients. In addition to those features, they also take in account if the patient is presenting with obstructive jaundice or if there is an associated solid mass to it. And then the same things, the main duct diameter should be more than 5 millimeters, cyst should be more than 3 centimeters, and there should be a change in the main duct caliber with an upstream atrophy. And then there are another 2016 Fukuoka guidelines that are used to work up the cystic lesions. So in addition to the cystic size, mural nodule, pancreatic duct size, they note that if there is an associated lymphadenopathy, elevated CA19-9 level, or a rapid growth of lesion of more than 5 millimeters in 2 years. So after the clinical guideline and categorizing the patients, then we receive the pancreatic cystic fluid analysis that can be done on the patients. They undergo cytology evaluation for those specimens. And in addition, there's some chemistry analysis for the cystic fluid that can be done. So over there, they're analyzing the amylase level and the CA level for the lesions. So if any cyst that is communicating with the main pancreatic duct, usually the amylase level would be high. Like in IPMN, there is increased amylase level. And if the cyst is cystic, like mucinous, if the cystic lesion is mucinous, then there would be an increased CA level. So mucinous cyst adenoma and IPMN have an increased CA levels. Other than that, the non-neoplastic category includes pseudocysts, so they can have an increased amylase, whereas CA would be in normal limits. So these are kind of the initial workups. So for IPMN, according to WHO, it has to be a grossly visible lesion, mucin producing, predominantly papillary or rarely flat, intraductal epithelial neoplasm that is arising from the main pancreatic duct or the branch duct. And the size usually goes to more than 5 millimeters in its size criteria. So the patients are either incidentally identified, which is in most of the cases, or they can present with symptoms like epigastric pain, chronic pancreatitis, or weight loss, depending on if that lesion is increased in size and it's causing those obstructive symptoms. The age range is usually in 62 to 67 years, and they have a slight male predominance depending on geography. So this is a cytology image I'm showing. So this is an example of high-grade dysplasia related to IPMN. So you can appreciate over here, the specimen will usually have high cellularity and the NC ratio will be high. Then there is an abnormal chromatin pattern. You can appreciate this is the mucinous epithelium, and there's a lot of necrosis in the background. So that is how high-grade epithelial atypia looks like usually in the cytology specimen with this cytoplasmic mucin. And if you compare it to low-grade IPMN kind of cytology findings, then you can appreciate the difference in between both of them. So this, as you can see, they will have kind of lower cellularity, but they'll still have these columnar epithelial cells, but the nuclei are more polarized. The NC ratio is less. By NC ratio, I mean nuclear to cytoplasmic ratio. So there is lesser number of, like, the ratio between the presence of nuclei to the whole cytoplasmic size is less as compared to the one that we saw previously. There is more abundant cytoplasmic mucin in there. The nuclei are still round and they are ovoid, and they generally have a smooth nuclear membrane. So there is absent nuclei in there, and we're not seeing any background necrosis in it. So that's when you're doing a cytology specimen evaluation, they can be labeled as low grade or high grade, and they can be labeled as this is suspicious for malignancy. But on cytology, you cannot differentiate IPMN and an other type of cystic lesion that I'll talk about later, that's called mucinous cystic neoplasm. Because to call it mucinous cystic neoplasm, you have to see a background ovarian stroma in those patients. So an ovarian stroma cannot be well appreciated on a cytology analysis or specimen. So that's why they're just labeled as cystic lesion, suspicious for malignancy, low grade or high grade based on cytology. So this, I'm showing you the imaging finding of IPMN. That's the cystic lesions in the pancreatic head usually, and then they can communicate with the main, like the bile duct. And then this is a gross imaging of one of the Whipple that was resected for main duct IPMN. So you can see the pancreatic duct that's dilated. There is some fleshy kind of lesion in here with some mucin. And on microscopy, this is a duct that is dilated with this lesion. That's main duct IPMN because it's involving the main pancreatic duct. The stroma on the sides is fibrotic, and these are all papillary excrescences, and they look pretty low grade over here. So the branch duct IPMN in comparison, that's the imaging finding in there, and it's not involving the main duct over here. So this is involving the branch duct of a branch pancreatic duct, and they usually appear as kind of multilocular or cystic lesion on the side. So that's what you can appreciate over here. And as we mentioned in the definition, they can be flat mucinous epithelium as well. So this is the main, this is the branch duct IPMN, and they are more so mucinous epithelium in a flat kind of lesion, and they're still low grade in this example, as the nuclei are pretty much maintaining their basally oriented appearance, and they're not losing their polarity, or they're not architecturally or cytologically very atypical. So as we were talking about in the scenario, when you diagnose somebody with IPMN, you have to also identify if there is a cancer associated with it. So if there is a cancer on Grossi, you can see they're more infiltrative and solid, and they're definitely different in appearance than the fleshy kind of papillary excrescences appearance that you will see in IPMN. So this is a cancer, grossly how it will appear associated with IPMN. And on microscopy, these adenocarcinoma kind of cells, they are not maintaining their lobular architecture, as you will see in a pancreatic parenchyma. They're more haphazard and infiltrative kind of glands that are arising from an associated IPMN kind of lesion. So adenocarcinomas that arise from IPMN, usually they are tubular adenocarcinomas. However, like in our first example we saw, they can also be colloid kind of carcinomas. That's one of the variants of the pancreatic ductal adenocarcinomas. And to call it colloid carcinoma, you have to see about 80% of mucin in the background with neoplastic epithelium, and they have relatively better prognosis as compared to the ductal tubular adenocarcinoma that's seen in the in the specimen. So if given that the patient does not show lymphovascular invasion or perineural invasion, and the lymph nodes are also negative. So another thing to note is that they can be concomitant invasive cancer associated with IPMN. By concomitant, I mean that they're not arising with IPMN, but those happen in about 4% of cases. And to identify them, you have to extensively sample the area between the adenocarcinoma and IPMN to say if it's concomitant or if it's arising from IPMN. So IPMNs can be multifocal, and as you can see over here, these are multifocal lesions, and when they're multifocal, they are independent genetic alterations that are present in those foci that are seen, and the usual alterations that are associated with IPMN include KRAS mutation and GNAS that's kind of specific with IPMN, or RNF43 mutations that are associated, alterations. Then microscopically, we discussed about how they will appear, but they can be 3 epithelial cell histology that can be gastric, intestinal, or pancreatobiliary. They do not have an ovarian stroma, which is a requirement for mucinous cystic neoplasm. So gastric type IPMN, as you can see over here, they're pretty reminiscent of the gastric foveolar epithelium seen in the gastric tract, and they are maintaining their kind of mucinous epithelium on the top and the 4-cell lineage seen in the gastric epithelium normally, and they are the most common type. They account for about 70% of gastric of IPMN cases. They are usually low grade. Then the intestinal type seen over here, they are showing, as you can appreciate, pseudostratified epithelium seen, nuclei seen in the intestinal type epithelium. Usually they're the second most type. They're counting about 20% of cases in IPMN. They usually involve the main duct and they're high grade. Then pancreatobiliary type IPMN involves the main pancreatic duct usually. And then as you can appreciate, they're more complex. They're more interconnecting papillae over here, which are composed of these cuboidal cells with amphiphilic cytoplasm, enlarged nuclei, and they can have prominent nucleoli. So they are regarded as usually high-grade lesions. So previously, IPMN was considered to be of 4 epithelial types: gastric, pancreatobiliary, intestinal, and oncocytic. But I'm showing you this paper, and with further categorization, they found distinct genetic alterations in oncocytic type IPMN. So now it's considered a separate entity, and they do not show GNAS or RNF43 mutations or KRAS especially that are more so associated with usual IPMN, but there was another kind of lesion that was genetic alterations that was found in there. That's called PIKACA DNA JB1. That's also seen in fibrolamellar hepatocellular carcinomas. So that was seen in them. That's why in new WHO they are categorized as a separate entity. So this is a gross image of IOPN, and these are the papillary or the lesion that's arising in the pancreatic duct. And as we were talking about previously as well, is the fibrotic stroma, the complex arborizing papillae. The cells have more granular cytoplasm as appreciated over here. Nuclei are still pretty round and they're maintaining their smooth nuclear contours. There can be some luminal appearance in the epithelium there can be some luminal kind of, as you can appreciate over here, in epithelium, there can be some luminal hollowing that can be seen here or there, but that's not important. The most important thing is that they're complex, they're arborizing in their architecture, and they can have these granular kind of cytoplasm. So that's, and the genetic alteration that's associated with them. So coming to from 2015, the new Baltimore consensus that recommended that IPMN previously was graded as low grade, intermediate grade, and high grade, and now they are categorized as only low grade IPMNs or high grade IPMNs. So that's according to the new WHO as well. So as we were talking previously as well, in low grade, there will be more basally oriented nuclei and abundant apical mucin, whereas in high grade, the nuclei, they are more stratified, they have more nuclear atypia, they're losing their polarity, and you can see some apical budding of neoplastic cells over here in high-grade dysplasia as well. So we talked about it. We have to figure out the invasive cancer associated with IPMN, whether it's concomitant or it's arising from IPMN, the tubular carcinomas, the colloid carcinomas, and then the invasive cancer is identified and as many as about 60% of main duct IPMNs. So to differentiate gastric, pancreatobiliary, and intestinal IPMN, there is another stain that's called MUC. So you can use MUC1, MUC2, MUC5AC, and MUC6 staining. Gastric type IPMN is stained with MUC5AC. Pancreatobiliary usually stained with MUC6, and the intestinal, like we saw in the first example, can stain with CK20 and CDX2. Then the staining pattern for IOPN and ITPN are different, as you can appreciate in the table, and they are staining with MUC1 and MUC6 and MUC5AC for IOPN, and for ITPN, the staining for MUC1 and MUC6 positivity. DNAS mutations are relatively specific molecular alterations that are seen with IPMN. Other than that, KRAS is most common and seen in about 60 to 80% of IPMNs. For staging, according to new WHO, it's based on size. So for PT1 to be subcategorized, it's further staged as PT1A, depending on if it's less than 0.5 centimeter, PT1B if it's 0.5 to 1 centimeter, and PT1C if the lesion is more than 1 centimeter. So there's another thing that's called PANIN. PANIN is a microscopic non-invasive lesion as compared to IPMN, which should be grossly visible or it's macroscopic. So the size criteria for PANIN is less than 5 millimeters. They are also considered precursor pre-invasive lesions for that progress into pancreatic ductal adenocarcinomas. So the entity, now there's a gray area that's also mentioned in the new WHO. The size between 5 millimeter and 1 centimeter. So that's regarded as either high-grade PANIN or incipient IPMN. So it is called incipient IPMN if on the epithelial differentiation, you're more so appreciating a pancreatobiliary or intestinal type lesion and there is a GNAS mutation associated with it, then that's categorized as incipient IPMN. Otherwise, if it's more so gastric type of epithelium, then that's considered as a lesion that might be an increase in size for a PANIN lesion. So these papers I have just put up to show you that the molecular or genetics of PANIN, that they share some of the genetic alterations in common with the pancreatic ductal adenocarcinomas that, like we mentioned before, TP53 and SMAD4. So that's why they are like a precursor non-invasive lesion. And PANIN stands for pancreatic intraepithelial neoplasia. So again, they can be low grade as seen over here, or they can be high grade. And the epithelial cells in almost all PANIN, they can have a gastric foveolar differentiation, whereas for IPMN, they can have different kind of differentiations like intestinal, in which intestinal is most common, but they can have different differentiations in the same lesion. So another cystic lesion that should be considered in differential is intraductal tubulopapillary neoplasm. That's one of the differentials for IPMN because it is still intraductal and they're predominantly tubule-forming epithelial neoplasms with high-grade dysplasia. And this is the gross finding for them. They can be as large as up to 15 centimeters and they usually involve the head of pancreas. So this is a microscopic image for ITPN, and you can see as they're very compact, they're involving the whole duct and they're back-to-back glands as seen over here. And the nuclei are pretty round and monomorphic, and they're in the form of these tubules, back-to-back tubules in there. So that's why they're considered high-grade. And this picture just shows you that we are in the middle of our presentation, and I just want you guys to have a break for probably 5 seconds. And these are my daughters, and we went to kayaking at one of the it's called Grand Rivers. It's in over here near our house in Canada, in London, Ontario. So that was a very fun experience and we really liked it. Okay, so after that breather, I'll walk you through some other cystic lesions of pancreas. So putting up a case scenario regarding that. So this is about a 57-year-old female, and she was followed up with hematology due to multiple myeloma. She has a history of cervical cancer, and she was complaining with mild acid reflux, dysphagia for both solid and liquid on and off. She denies any black or bloody stool, nausea or vomiting, any recent fevers, any obstructive jaundice or dark urine. She has a social history of 3 to 5 packs per day for smoking for up to 50 plus years of history. Her maternal grandmother had a history of pancreatic cancer. So on imaging, they saw an enlarging cystic lesion as appreciated over here in the tail of the pancreas, and it measured about 5 centimeters. 3 years ago, it was measuring about 2.3 centimeters. So you can see there was an increase in the size. So the pancreatic ducts, they were not dilated and associated with that lesion. The CA level was, however, very high. It was about 3,000 in numbers. The amylase was within normal. And then distal pancreatectomy, it showed that that was a tan, white, well-circumscribed cyst with clear yellow fluids. And the mass from the pancreatic, the mass was about 1.7 centimeters from the pancreatic cut margin. I can show you the microscopic image of that. So as you can appreciate, this one on the background is the normal pancreatic parenchyma. This is a cystic lesion seen on microscopy. And if we go on high power, you can see that there is something, this is not like a fibrotic stroma. The stroma looks more busy over here. So on top, these are the like kind of the epithelial cells, and they're lined with this spindly bluish stroma that is termed as ovarian stroma in here. So this lesion was categorized as mucinous cystic neoplasm. So by WHO definition, they are mucin-producing cysts. They consist of neoplastic epithelium that are associated with distinct ovarian-type subepithelial stroma. They are more so present in women, ranging in the age range of 14 to 95 years. They're small tumors, more like less than 3 centimeters, and they're incidentally found. They can be larger. When they're larger, they appear with obstructive symptoms and vague abdominal pain. So this is a cartoonish image just to show you mucinous cystic neoplasm, how those cysts look like on imaging. And they're usually single cysts with multiple daughter cysts in it, as appreciated over here. And they're not communicating with the pancreatic duct. So there's no pancreatic duct dilation that's seen. So on gross, it can also be appreciated. This is the main pancreatic duct, and it's not involved by these cystic lesions and as in here. They are solitary, they are thick-walled. They usually involve the body or tail of pancreas. So depending on their size, if they are more larger, like more than 5 centimeters, they can be more so associated with invasive cancer in there. So microscopically, you can see there are multiple cysts. They're lined by the cells with mucinous epithelium in here, and they can show a background ovarian stroma, which is usually as like spindled cells. And over here, sometimes the ovarian stroma is not appreciated. So the stroma is more fibrotic as seen in this example, but then you have to extensively sample them, and there are some markers that can be used. So same way, densely packed spindle cells with scant cytoplasm in here, they have uniform nuclei, and this is the ovarian stroma. They stain positive with PR and CD10. PR is a nuclear stain, as you can appreciate here, and this is a CD10 staining that is also positive in ovarian stroma. So they can be categorized as low grade and high grade as well, as we were categorizing IPMN before based on their atypia. This is one of the papers I put up from literature to show you that 15% of mucinous cystic neoplasms, they are associated with invasive cancer. And it's the association with invasive cancer has been usually seen if there are irregular thickening of cystic wall, if there is an associated mural nodule, the size is more than 5 centimeters, or CA19-9 level is higher. So this table has been put up just to show you the different molecular alterations that are seen in different cystic lesions. So IPMN usually shows KRAS genus RNF43 mutations. If IPMN is associated with advanced neoplasia, then there can be then there can be TP53, SMAD4, or mTOR pathway alterations in there. Mucinous cystic neoplasm does not have GNAS associated alterations. They are more so associated with KRAS and RNF43 alterations. Then IOPN, like we mentioned before, has PIKACA and PIKACB fusion genes. Serous cyst adenomas are associated with von Hippel-Lindau mutations. Cystic pancreatic neuroendocrine tumors are associated with MEN1, and solid pseudopapillary neoplasm have CTNNB1 alterations in there. So we'll talk about them later as well. Just the purpose of showing you that there are different molecular alterations is one more thing, that this one is from the latest 2023 multi-institutional prospective study that involved around 31 institutes in the United States. So this is something that's in play that might be more so common in practice later on, but it still is going through some validation. But what they did was that they did an NGS panel, that's PancreaSeq, that was first performed retrospectively on the pancreatic cystic lesions. And then within a 2-year time frame, the PancreaSeq testing was prospectively used to evaluate the endoscopic ultrasound-guided FNA needle aspirated pancreatic cystic fluid from all those 31 institutions. And that was correlated with the ancillary studies and the pancreatic cystic guidelines that we were seeing in the start and followed up, and then how it can be used to correctly diagnose those patients. So in that study, they found out that like the normal guidelines that we were seeing before, the ACG and AGA guidelines, they had relatively low sensitivity and specificity. And if we added PancreaSeq testing to that, it increased the sensitivity and specificity of those tests. And that's why it increased it from 72 to 96% for the advanced neoplasia, and it increased from 86 to 98% specificity for detecting those cases. So in addition to that, same way for cytology, we know for cytology specimens, the specificity is around 100%, but sensitivity is low. It varies from 25 to 88%, depending on if you're able to correctly take out the specimen, because there can be a difference in the cellularity when you are doing a cystic fluid analysis. So when they added PancreaSeq testing, like the molecular testing, to the cytopathologic evaluation of the studies, so that increased the detection like sensitivity, and more so they figured out that there was more high specificity for detecting advanced neoplasia in the cases. There were some limitations of the study, but I have just put up this paper just to correlate that there is this NGS testing that is being done, and the molecular testing is on the way to be regularly probably implemented in future for the diagnosis of cystic lesions of pancreas, because of the high specificity of detection that's associated with it, as per it has been tested till now. So now we will go to another case presentation. So that was a 58-year-old female who was having nausea and belching after meal, and she had an intense pain, and she was under her right rib cage. She denied any history for weight loss, reflux, jaundice, GI bleeding, or she did have a history of pancreatitis. So her pancreatic tail showed a cystic mass that measured up to 2.4 centimeters, and it did not communicate with any main pancreatic duct or side branch kind of lesion. So on EUS or ERCP, there was a limited cellularity in that specimen, and they showed more so benign appearing group of glandular epithelium with minimal mucin. So this is the imaging. So that was the pancreatic tail cystic lesion that measured about 2.4 centimeters. So I just put it from the gross imaging of that patient. So as you can see, this is the pancreatic duct, and that's the cystic lesion associated with it. And on microscopy, that's the normal pancreatic parenchyma. So this is the cystic lesion. And as you can appreciate, there is no hypercellular or ovarian kind of stroma in the background. That's just kind of bland stroma. And all those cells, they are very kind of cuboidal and low-grade epithelial cells that are surrounding that cystic lesion. So it was diagnosed as benign oligocystic serous cyst adenoma. And the other pancreas there wasn't any malignancy associated with it. So for serous neoplasms, they account for about 1 to 2% of all pancreatic neoplasms, and they account for about 10 to 16% of surgically resected cystic lesions. So this is a cartoonish image showing that serous cyst adenoma, and they can have kind of a central scar in the middle and some peripherally located cyst on the sides, and they are more so present, as you can appreciate over here. They can be macrocystic, solid, associated with von Hippel-Lindau, or they can be mixed in association with other neuroendocrine kind of neoplasms. So by definition, a serous cyst adenoma is benign epithelial neoplasm that is composed of glycogen-rich cells that form the cyst containing serous fluid. They can be present in any age range, a slightly more predominance in women, and the age that they're more so, median age range is 58 years, and they are present about 75% of cases in pancreatic body or tail. They're generally solitary, and they're associated with von Hippel-Lindau disease. So on imaging, they are well circumscribed and multilocular cystic mass. They can have a central scar, and the radiologist can also point it as honeycomb pattern. They do not communicate with the pancreatic ductal system, and the serum tumor markers are within normal limits. This is a gross finding I'm showing you over here. So there are multiple smooth, these are smooth walled cysts that contain clear serous fluid, and this is the tail of the pancreas that is involved with this honeycomb cysts in here. And the oligocystic variant will show more so peripherally dilated cysts and that are associated with this central scar. On microscopy, you can appreciate that these all glycogen kind of like glycogen containing cells that are more cuboidal, they're lining all these cysts. And then this I just want to mention, this is very rare to call it serous cyst adenocarcinoma. There are about probably 20 cases that are yet reported in the literature as serous cyst adenocarcinoma, and that is only based on, like, histologically they will appear same as serous cyst adenoma, but based on metastasis they're called serous cyst adenocarcinoma. So all those cases were seen metastasized to pancreas or liver, involving the liver or other parts. So that's why they were called as serous cyst adenocarcinoma. So on staging, the serous cyst adenocarcinoma, they are staged as carcinoma of the exocrine pancreas, and they can, all those glycogen type cytoplasm, they are PS positive and diastase sensitive in those cells, and they are positive for inhibin as well. And like we mentioned, there are VHL deletions in the von Hippel-Lindau patients on chromosome 3, and they do not have KRAS TP53 GNS or RNF43 mutations that cannot be identified in them. So coming to another case presentation, that was a 29-year-old woman, and she presented with a mass in the distal tail of the pancreas near the hilum of the spleen. First, it was thought that maybe it is a splenule. So this is the lesion over here in the pancreatic tail, that cystic lesion. And then on cytology, CEA was 1, CA 19-9 was 8. On cytology, you can appreciate this is pretty different from what we have seen before. The cells were forming in the pancreatic tail cystic cell mass cells. When they were evaluated, they were forming these papillary excrescences, and they stained strongly with beta-catenin, CD10, synaptophysin, and CD56. So on the cell block, this is the pseudopapillary appearance of those cells. They are on the periphery of these lesions. The cells have their nuclei arranged, and they're pretty kind of degenerative or monomorphic kind of cells. And in the middle, these the core of the pseudopapillary structure will have more hyalinized or myxoid stroma in the middle, and that is involved by the cytoplasm of those nuclei that are present in the periphery. And this is a smear that shows very monomorphic cells, but that's why the differential for these lesions is cystic neuroendocrine tumors, but then they do not have salt and pepper chromatin. That's more so seen in neuroendocrine tumors, and these ones are negative for chromogranin as compared to neuroendocrine tumors. So that's the microscopic image of them. They look pretty solid in here, but if I go on high power, this is a pseudopapillary appearance of them. You can see these some kind of vascular like these all cells, they're arranged around these vascular papillae in here, and coming on more higher power, those vascular papillae in the center, they have more so myxoid kind of stroma, and on the periphery they're lined by these monomorphic appearing cells. And then another characteristic for those cells I'll mention later as well is these hyaline globules that can be seen in solid pseudopapillary neoplasms. So these neoplasms have uncertain cellular differentiation. They are more present in adolescent girls and young female, and they can be incidentally found in the patients. So that's the imaging finding. These are the cystic part. They can be solid and cystic. So that's why radiologists can point it out as floating cloud sign in their imaging or scans. And on gross, these cystic lesions can be hemorrhagic and cystic as seen over here. And this is a pseudopapillary pattern of them. They are solid nests with poorly supported thin vessels as seen over here. And the farthest cell, like I mentioned you before, they can undergo some degenerative changes where the cells that are more so near the vessel, they are more intact. So those nuclei, they can have some grooves in them as well as seen over here, the nuclear grooves, and the degenerative changes are seen in these images. These are the foamy macrophages, and they can be some cholesterol clefts that can be associated with them. And like we knew that the mutation associated with solid pseudopapillary is CTNNB1, so that causes this beta-catenin stain that can be used to diagnose those patients. So that causes normally the beta-catenin will be a cytoplasmic staining, but due to this mutation, the beta-catenin moves from cytoplasm to the nucleus. So that transcription causes this nuclear staining for beta-catenin that can be appreciated in the patients. Then other than that, they're positive for cytoplasmic CD117, nuclear beta-catenin as mentioned over here, then PR, CD10, CD99, and it can be positive in the patients. So LEF1 is another marker. I just put it from one of the like research papers that can be diagnostic marker for solid pseudopapillary. If it's available in the facility, and the staging is according to the exocrine carcinomas of the pancreas. So one of the differentials, like I was telling you, is cystic pancreatic neuroendocrine tumors, because they can be very monomorphic in appearance on cytology as well. So these can be solid or cystic, and the cystic component can have serous fluid. So they are associated with MEN1 patients. And then they're also not very common, they're rare. So this image I just put from one of the case reports to show you like how they come in differential to the solid pseudopapillary lesions. So the neuroendocrine tumors will have neuroendocrine markers positive. They will be positive for chromogranin, and these are more so monomorphic and organoid or solid kind of cells that can be seen. And on cytology, they are monomorphic, but they can have these salt and pepper kind of chromatin that can be diagnostic for neuroendocrine tumors. So coming to the second last case of our presentation today, just to give you an idea that besides this neoplastic and other lesions, they can be non-neoplastic pancreatic cysts as well. So this was a 36-year-old male who had a history of heavy alcohol use, and he was being worked up on endoscopy. There was some gastric varices that were seen. So incidentally, on CT scan, there was a mass in the pancreatic tail that measured about 3.9 centimeters. So this is the imaging finding of that. And then on imaging, it was, although CA 19.9 was within normal, CA was okay, FNA was not possible because of some safe window associated with biopsy. But that was very concerning for pancreatic adenocarcinoma on imaging. So the patient underwent surgery, and as you can see, they found this cystic lesion. But one thing to be noted, I'll show you in the higher power, is that cystic lesion was not lined by any epithelial kind of cells. So everything that was lining the cystic lesion was either inflammation or macrophages or some granulomatous reaction. So this was termed as pseudocyst. So pancreatic pseudocyst is one thing to keep in differential for cystic lesions of pancreas, because it's one of the benign or non-neoplastic cystic lesions of pancreas. It's more so present in patients with a history of alcoholism, and they do not have any epithelial lining the cyst of the pancreas. So coming to the last case of our presentation today. So this was a 32-year-old female. She presented with right upper quadrant pain. She had a history of resection of about 10 centimeter retroperitoneal lymphangioma in the past. On her recent imaging, she had a CT scan. She had, as you can see over here, she had a 5 to 2.5 to 3 centimeter abdominal mass that was abutting the liver, second and third portion of duodenum, inferior vena cava, and pancreatic head. So on resection, these are all the cysts that can be appreciated over here. And there's some lymphoid aggregates in the background as well. So those cysts have some proteinaceous fluid in there as well, as you can see. And these are the proteinaceous fluids. And those cysts are lined by these endothelial kind of cells. And they stained positive for D240, CD31. So this was categorized as lymphangioma in the pancreas. So that's also one of the non-neoplastic cystic lesion that can be present in pancreas. So besides that, the other things to keep in differentials can be other non-neoplastic cystic lesions like retention cysts or simple mucinous cysts. So those are all the other categories that we saw in the start. So thank you so much. And this is just a picture of my family. And this was after a roller coaster ride that we took last year at Universal Studio. And we are still smiling after that ride. So I hope and I'm sure that you guys might be smiling after all this roller coaster kind of presentation, and hope it helped you understand the approach towards diagnosing the cystic lesions of pancreas in a much better way. Thank you so much. Thank you.
Yes, thank you so much, Dr. Zia, for your mentorship and teaching today. So I'll now begin our Q&A session. My name is Amna, and I'm an undergraduate student at the University of Maryland. I'm on the pre-med path. So our first question for you is, what do you think are the biggest misconceptions people have about the field of pathology?
That's a good question, actually. What are the misconceptions that people might have of pathology? So when I was rotating during my residency as well, and I figured out that probably during med school, sometimes there is, maybe I'm not sure, maybe it varies from medical college to medical college, but sometimes maybe seeing Dr. House or other series, people do think that if you're a pathologist, you're more so involved in maybe only autopsy or forensic service. But to tell you honestly, there is a lot of diagnostic work that goes into play in the background that involves all the fields. Like pathology is subdivided into anatomic and clinical pathology. So in anatomic pathology, we are dealing with all the surgical specimens, ranging from biopsies to dissections and everything probably that comes into hospital, like the patients, the tests that they're going through. The CP rotations deal with blood bank, transfusion medicine, so the plasmapheresis procedures for patients. Hematopathology deals with bone marrow biopsies. So tumor boards that we are covering that are related to correctly diagnosing and staging the patient. So I think that's a very responsible and patient-oriented field, and sometimes it can be misinterpreted as that is a very important part, definitely dealing with autopsies and forensics and giving the medical legal reports, but that's not the whole world of pathology. Pathology is a vast diagnostic and related to staging and giving the correct, I think, basis for patient management kind of very responsible field. So I think it can be maybe misinterpreted sometimes as one subspecialty, although it has a lot of other subspecialties associated with it.
Thank you so much. That was very insightful. So our next question is for you. What got you interested in pursuing the pathology specialty?
Oh, I would not say that during med school, because as I was mentioning, sometimes there's not that much of an exposure towards pathology. Like it is part of or integrated in the curriculum, but we don't get to see the whole side of it. But as I was rotating to different rotations, so when we moved to Canada and then I rotated at very prestigious institutes, I would say, and I got very lucky during my rotations that the mentors were very nice and helpful. So I rotated in Indiana University, Brown, and Buffalo. And during those rotations, just to see, especially the frozen sections, I was very intrigued to see that whenever somebody is going through a surgery, and the frozen section is a part of pathology where they will send that like a part of the tissue, and they want you to give a diagnosis. Like, you have to cut the tissue right then and there, you have to freeze it, you have to stain it, and tell the diagnosis regarding what you're seeing, if there is a malignancy present or not. And within a time frame of usually 15 to 20 minutes, so it's in the back side of the OR. And I saw that how it changes, or it helps the other clinicians and surgeons to make the decisions regarding patient care. Like, for instance, they'll send lymph nodes during a mastectomy procedure, and they can decide if it's positive or negative based on that, if you're gonna do a lymph node dissection for the patient who is undergoing mastectomy, or for instance, if somebody is having a Whipple procedure, then based on if the margin is positive or negative, they'll alter their surgeries. So that was one part that really got me excited about pursuing pathology, that how we can help and contribute towards patient management, and how responsible it is towards diagnosing and staging the tumors. Yes.
Got it. Thank you so much. So a couple of students in our audience were interested in possibly pursuing research opportunities in pathology to figure out if this is the right field for them to pursue. So can you tell us a little bit more about your own research, and if you have any recommendations for anything else students should be doing if they're interested in pursuing pathology?
Yeah, that's a good question. I think when anybody is trying to figure out their career goals, or they want to know what side they want to pursue, then probably like many other specialties, I think one of the things is that you should rotate in that subspecialty. Yeah, you should have a feel, and even during your med school, or I know as an international medical graduate, you can have those options of doing some observership. So I can maybe send you a list. I might have one for different observership opportunities for students that they can apply all over North America for pathology rotations. Now with COVID, there were, I know during last 2 years, many opportunities that came online as well, that students can have some Zoom observership rotations as well, to have a feel of the rotation, or how it is structured. So that's one of the options, I think, just to interact, just to reach out, email people. And there are some formal observership platforms in there as well, where you can send your CV and apply for a rotation in that particular field, and then see if that aligns with your interest, and you can apply in there. So yeah, I forgot the other part of your question. You asked me
about your personal research projects.
Okay, so I have been because I am very interested in the academic side of it, like teaching and getting involved with med students and residents. So I have been actively involved in, there is one international platform regarding pathology that's called USCAP. So they have their deadline every year in which you can submit your abstracts and your research work. Other than that, there are other national platforms like CAP, that's called College of American Pathology, or there is regarding GI, there are two main societies. One is called GIPS, GIPS, and the other is Pancreatobiliary Society. So I have been a part of those societies, and I have been participating, and I follow up the work over there. So I do have done some research projects regarding, I think, GI dysplasia. One of the recent ones that I participated in was in the past national meeting. So that was, we were trying to see the grading of the dysplasia in the Barrett's esophagus, and we tried to compare it to how you will evaluate it and grade it in person, to how the COVID has changed it, and when people send some virtual consensus, so how they can correlate it, and what was the concordance between the virtual grading of dysplasia in the Barrett's esophagus to how it was graded in an in-person consensus review. So that is one most recent one that has come to the top of my mind, but might be others.
Yeah, that's very interesting. And thank you so much for sharing all those resources. I'm sure that's very helpful for our students. So our last question, as we saw a couple of your pictures of your family, how do you manage your work-life balance?
That's nice. So I think that's a challenge probably all the times. And then one thing for sure is that I'm very lucky. I would say that I have a very supportive family. And no matter, it's not only in medicine, whatever you're doing, I think work-life balance is very, very important. And you have to kind of prioritize your day. Definitely when we go to work as a physician, patient care comes first. So even in that, if you see in managing your cases, when you go in the morning, you're like, this is a first time diagnosis or a first time mass detection, or like the priority cases or first out cases. So same way in your life, I think you have to prioritize like what is important, what is not, and allocate your time. Just become more organized. And I would say for me, my daughters have kind of grew up with me. I little bit got married at an earlier stage in my career. So they have seen me studying for USMLE and board exams. So one good thing or the lucky thing that happened to me is they're also very much into books. So we are kind of studying together. We go to libraries a lot, and then I play with them a lot. So that helps me, quality over quantity. So that helps me interact with them, and we have kind of become friends over the period of time, and which is very, very important. I feel like even with your family or your personal relations or your friends, it depends on how much amount of time you're spending with them and what is that time. Like you can be in this age and time on media or a phone or something else, or you can be talking to each other or playing and get to know each other. And then I think communication is the key. If you can communicate that you are busy at this time and you're doing this thing, and you have a good relationship, then anybody would understand, and it can be helpful to find a better work-life balance in that way. Yeah.
That's great to hear. Thank you so much. So those are all the questions we had for today. We really appreciate you taking the time out of your day to mentor us and be here with us today. I'd love everyone to please give a warm thank you to Dr. Zia in the chat box for this incredibly informative session. Thank you.
Thank you. Thank you so much.
All right, now we're going to conduct our closing session with our quiz and future session dates. So the link to this, the quiz for this session is now live. And again, you'll need a 70% or higher to pass and receive certification. And that link is sent in the chat now. On to our next session dates. So these dates will also be posted on our social media outlets. So be sure to follow us at TeleShadowing everywhere. October is cardiopulmonary month. So our next session will be next Saturday, October 7 at 10 a.m. Eastern Standard Time with a physician specializing in pulmonology. Thank you so much, everyone, for attending today's session, and we hope to see you in upcoming sessions as well. And this concludes this week's shadowing. Thank you.